This conference will now be recorded.
Awesome. I'm going to turn it over to Kate to introduce our speaker.
Hello, everybody, and welcome to today's webinar. My name is Kate Senyum. I'm with the National Rural Health Resource Center. I just wanted to take a moment to introduce our speaker today. Her name is Pat Scow, and I'm sure for many of you she needs no introduction. Pat is the Executive Director of the Illinois Critical Access Hospital Network, better known as ICAN. And ICAN was actually the first statewide critical access hospital network, which was established in 2003, and it comprised of more than 50 critical access hospitals, providing a number of hospital support services and educational programs, as well as managing the Medicare Rural Hospital Flexibility Grant, the SHIP program, and several other grant programs. We are thrilled to have Pat on here today with her wealth of knowledge on network activities. And I just wanted to remind everyone, so we sent out an assessment earlier this year and got fantastic feedback from SHIP coordinators and state office directors throughout the nation. And one of the major requests was to have more of these type of activities where we had learning collaboratives to share best practices, and so that everybody throughout the nation could learn from high leading states. So we're very excited to provide this today. And as a reminder, we will also, this is just part one of this learning collaborative, and Pat will also be leading part two of this learning collaborative, which will be held on August 23rd. And Maddie will have more information that will be sent out to you on that, as well as at the end of this presentation. So this time I'm going to turn things over to Pat to get us started. And Pat, we did have to put you on mute just because we were getting a lot of echo from other people's computer speakers. So you will have to press *2 to unmute your line.
Can you hear me okay?
Yep, we can hear you now. Thanks, Pat.
Oh, wonderful, wonderful. Well, thank you for the kind introduction, Kate, and welcome neighbors and friends from across the country that are involved with SHIP and FLEX and the National Rural Resource Center and Federal Office of Rural Health Policy. We've all become one big community and family, and I appreciate being able to spend some time with you today and share some experiences. And some of you may have great experiences working with SHIP, and some of this may be new to you. And I thought what I would do is go through a few items with you first. Just talk a little bit about the SHIP program, where it came from, and sometimes helps to understand why changes are made and why programs develop the way they do. I'm going to talk a little bit about, figuring out needs of our hospitals, how to assist hospitals to choose the best solution for them, working with them. There's no one right answer for everybody. I mean, we all have different hospitals and they all have different needs, but there are some collective things that we can do together. Different resources available, if you haven't done or put together a consortium, how you might go about doing that. And then really after you've done that, how do you promote activities within the hospital community? And so let's go ahead and get started and go through our journey here. Believe it or not, I've been around since SHIP started, and I remember I'd started with FLEX in 1999. And, they added SHIP in the early 2002. And it really came about because of another, act where they were looking at the Medicare prospective payment. They were increasing the billing changes going on in the outpatient area. And then, lo and behold, HIPAA came about at that time. And they really wanted to help small hospitals under 49 beds. We started with the critical access programs, but there are tweener hospitals, and I know you're all working with both groups there, and they really felt that there was a need. There was just kind of operational needs that when we have new regulations and changes, is there some kind of a grant program that can kind of fill those gaps? And so back at that time, 2002, it was really different kind of a payment system, prospective payment system for outpatient. It was really going to throw small hospitals and really a real change period. And then, like I said, we had to work on HIPAA and, of course, quality improvement. And that time, they had come out with the Institute of Medicine came out with all the quality improvement things that needed to be done and how if we really focused on reducing medical errors, the number of lives we could save. And that was a real awakening for some of us that have been around in the hospital community for years. We just, all these things have developed over time, and we didn't realize, some of the programs that we had put together over years in the 70s and 80s and 90s, that we really needed to make changes. And so that was really some opening for that. So the federal office and Congress, put the act together and created the SHIP program. And like I said, it really was to help individual hospitals with funding needs, for HIPAA training, because we all had to learn it quickly. It wasn't something that we all had in school. And, we were also learning about how to better place patients in hospitals, a lot of admission criteria, a lot of things like that. The hospitals were beginning this transition. And then, they were also folks at the federal office, when they rolled out the SHIP program, they said, what if we could develop a part to it where people could pool their money? So instead of a hospital getting $9,000, if 10 hospitals went together and shared their money, they'd have $90,000. And so maybe that would help hospitals coming together, might be able to do a program or buy some software that they could share things with. And so that's really how all this stuff took place. And so I think it's important to have that background information for some of you newbies and those that have been around for a while. Maybe it was just a walk down memory lane. But over the last several years, past 16 years, there's been steady changes as new regulations and electronic medical records and more work with privacy and compliance have come around. And of course, we had all that new coding. So the SHIP program changed. Every time we added something, it was really good that they developed this program to provide flexibility. Like I said, it's kind of filling those gaps. And so when ICD training on, there was a new focus. Let's kind of push our hospitals to take advantage of educational needs for coders or software training. And so ICD-10, we spent a lot of efforts with SHIP to get that going. And of course, reporting and hospital compare, quality improvement. Of course, in 2010, we had the Affordable Health Care Act, which allowed money then you could use towards accountable care organization, patient-centered medical home, and so forth. And even now we're moving into bundling. And so you can see how over the course of the last 16 years, when there's been different changes going on in healthcare, how the program has really evolved with it, because the goal, once again, is to help fill those gaps in those hospitals. And I think, it's really been beneficial to hospitals because, they probably wouldn't have had all that funds for ICD-10 and HIPAA training and things like that, because maybe they're not big dollar amounts, but sometimes it's just enough to be able to accomplish the needs that the hospitals have. So, okay, now you're the SHIP program coordinator, and you go, oh gosh, how did I get that title? Sometimes we wonder how the jobs that we end up with. But I really hope you're enjoying it. It's really a very, it's a fun grant to work with because not a lot of details, but there are still parts to it that you have to be concerned about. But I think, if you're new to it, you're going to wonder, how does this all work? But I thought, as a SHIP program coordinator, you're really responsible for the state application. And then you have to make sure that the program then gets implemented. I mean, it sounds kind of corny, just those two things, but there's really a lot to it. You have to be able to identify, notify, eligible hospitals. You have to make sure that they're not an 85-bed hospital that's applying for a SHIP grant. All those kinds of things. You got to make sure they're in a shortage area. And So there's some work in making sure that you have the right hospitals. And surprisingly, over the course of time, a hospital may not have qualified for SHIP, but maybe they've reduced their bed size down to less than 49 beds, and that works for them. And there are sometimes states have advantages. If you're less than 49 beds or you're less than 100 beds, you have different kinds of Medicare or Medicare, Medicaid, and other kinds of guidelines help. So, sometimes hospitals will reduce their bed size, and so you want to make sure that you're always checking your number of eligible hospitals to make sure that they are eligible and give them the opportunity to apply. And of course, you have to coordinate the individual hospital applications. You got to get them out and sent, and then you also want to present options to the hospitals. What are they going to use their funds for? And then, of course, you got to make sure we meet the intent of the SHIP program, and we'll talk about that in a few minutes. And of course, comply with the requirements of the grant program. And that's something that you as the SHIP coordinator have to make sure that all the I's are dotted and the T's are crossed. And if you're new to this, you're going, okay, well let's figure this out. Now, if you are new, this will be somewhat new, but if you've been around the journey with me before, you'll remember some of these same things. But over the course of time, as I said, the SHIP has evolved. We also wanted to make sure that hospitals were participating in certain programs. We don't want our rural hospitals, using the old term, left behind. We want them promoting their quality. We want them participating in patient satisfaction surveys, and we want them to be in the standards. And so what SHIP did was, okay, hospitals, if you're going to be able to have these funds available, you need to meet these basic requirements. So if you are reporting into COMPARE, you are already got ICD-10, and I really think almost 100% of people are using ICD-10. I think everybody's really pretty well compliant with it. The critical access hospitals, you have to be participating in the Medicare Beneficiary Quality Improvement Program. Those that are non-critical access, you have to obviously be in the quality program. And then, of course, once you've completed those, you've met those requirements, there's more flexibility to that. And you, as the SHIP program coordinator, you often have to be the one to help guide the selection. And if you're new to it, you're going, okay, well, what does that all mean? So if you're the individual or consortium, hospitals have to choose how to use the funds individually. And so, once again, going back to the requirements, before they can look at anything, have they met, the reporting requirements, ICD-10. And sometimes, you can use the hospitals, if they're going to use it individually, that they can use the two things from it. I mean, they can use the part of the funds towards patient satisfaction, and the remaining, maybe they're working on an antibiotic stewardship project or whatever. But they can apply to 2 or 3 different programs. Also, if the hospital wants to participate in a group program, what might that be? So hospitals, they have 2 choices. They can participate individually, or they can participate in this consortium. They can actually, I use the term, pool their funds. I've had in the past, I had 3 hospitals that came together, and they said they really wanted to do some lean training. Could they do that? And so they pooled their funds and they hired a consultant, and voila, they had they had lean training for a whole year, and they were able to get all their hospitals through. Individually, they could not do it because they couldn't afford the consultant. So you give the hospital some options in moving forward with that. So if you're the program coordinator, you go, well, why? Maybe these hospitals got it all figured out. I do the same thing over and over every year. But really, why do I have to help? Why do I have to explain this? And, I ask myself, I've been doing this for a while, what makes the difference? And, surprisingly, we have hospital CEOs, change over. And sometimes the hospital CEO will ask a grant coordinator within the hospital, or maybe it's the quality director or the chief nursing officer, whoever has been doing it, that's their assignment, and maybe they left last year and you've got a new person. So, you have to go through this process over and over and over. And sometimes the SHIP hospitals aren't quite sure of the program choices. They just, when if they're new or you've only done it once and, maybe there's a change to it, a new requirement, they're just not quite sure. So, you really have to think about all the information you need to provide. And maybe in the past, the hospital's not been interested in the program. They think, I have sometimes hospitals say, it's just too much work. The grant coordinator, she's got 2 other projects. She just or doesn't see the value in the program. And maybe, with a little extra time and an individual call, they have a better understanding of the program. Or the hospital now is part of a system. Can they still participate? Of course they can. But maybe they don't know how to apply for the SHIP within the system. So I have to kind of work through them and help talk about what might be the best solution. Or they really want to pull their funds, for some kind of a group activity. And you want to make sure that some states do it differently. Some states give the money up front. Some of them, they have to complete their project, before they get the funds. I mean, there's a variety of ways of doing it. Depends on your state grant program and their accountability. But you don't want to end up at the end of the 12 months of the project and the hospitals have not spent their funds. So you really want to have some preparation in there and why you want to help, why you want to be a step ahead of the whole program and process. So how do you identify hospital needs and ideas? And, if you don't have, like Illinois, we've been fortunate that over the time we have this network, which I'm now responsible for, but if I didn't, I would want to have an advisory committee. If maybe you only have 10 SHIP hospitals in your state, maybe you have 80, a variety of ways. And you want to know, how can I best help these hospitals use their fund and better understand the program? And I really like having some kind of an advisory committee, whether if you're, an education committee, whatever you call it. But find those champions, people that you're working with, or ask for volunteers, and just, a simple conference call with an agenda and list of ideas, get their feedback. Set up a call and say, please, most of the hospitals, because you're in the state office, they're going to be more inclined to participate with you because they know it's important. And so they'll get on the call and you simply walk through the program. They'll give you feedback. They'll tell you what areas and the gaps that they have. Some states use what they call a needs assessment. Just do a survey monkey, If you've got all their names, send out an email to them and say, would you be so kind as to do, tell me what your needs are, and I'll help put some projects together. Different ways that you can do it. Or you can work with the hospital association or a network or an organization that you have, a rural health association. Anybody, other ways that you can find out what are the hospital's issues. Or else you simply can, there's a lot of information through the Flex Monitoring Team or iVantage or National Rural Health Association, the associations, hospital associations. There's lots of financial data, compliance survey issues. What kind of issues are out there? We see a lot about hospitals being in trouble, under 700 hospitals or more that have financial issues. So you may want to try to help steer the hospitals towards using, if they've done all their ICD-10 and everything, some kind of financial program. Of course, there's always new programs and trends, bundling projects. In our state in Illinois, we've got a big push on crisis prevention training. And there's always stuff now with meaningful use that program's going to weigh. They're still going to have to report that if they're part of the quality program. And so what can you do to help them to have a better understanding? So finding out hospital needs really come in all different packages. You could have advisory, assessment, or you can work with associations, or you can just simply look at the data that everybody has available. Or, you know, there's always new trends, like back in 2002, we had HIPAA. Well, who knows what's going to be next, especially as we move forward in population health. So the process, you know, you're having to put together the state application, and if you're going to offer different programs and explain what the hospitals are going to do, you want to start early enough to get the hospital's feedback. So if you're doing a needs assessment survey or an advisory committee, you know, you want to make sure that you get that call in, you know, a couple of months before you have to start working, or a couple, or even during the beginning of your grant project. Is, you know, how are you going to do that? Maybe you want to talk with systems. You know, several states have a number of systems that have several critical access to small rural hospitals. You know, if you have a contact there. But you might want to talk to another SHIP coordinator. You know, I think one thing I've always been impressed, those involved in the National Rural Health Resource Center or the federal office programs that, you know, the National Center helps to promulgate, is the friendliness and the willingness to share. There's always somebody willing to help or provide an idea. Or look at what you did last year. How did the hospitals do? Did their funds spent in time? Did they have questions about it? You know, all this big thing is start planning early. And, you know, really I've always had, you know, sometimes we end up being last minute, and I'm going, I've got to get that information out to the SHIP hospitals so that they know when they're filling out the applications that there are options. And, you know, and I make a list of things for them, and I do a webinar for them because they really need that feedback. But, you know, especially, like I said, they may be new. Maybe the hospital didn't participate last year, and boy, that $10,000 looks awfully good. So when you get the feedback, you know, how are you going to communicate that process? And, you know, the hospital, you know, the SHIP coordinator, you know, from the federal office will give some ideas. The National Resource Center usually does a promo at the beginning of that. And, you know, maybe you've seen some programs on revenue cycle. Gosh, look at all the emails we get every day. I always know that they need some kind of compliance training or quality program. Credentialing is a big factor anymore. Hospitals, you know, people are retiring. A lot of folks are retiring, and you have to learn this credentialing process. It's really hard to know how to do a credential of a new medical provider, whether it's a nurse practitioner or a new physician. And the hospitals constantly have to do that. One thing we find that with the workers' comp and with professional liability companies, they're really looking for hospitals to be involved in patient safety organizations like Clarity out of Wisconsin. Some of those kinds of programs, you know, the hospital, you say, you know, maybe a patient safety organization, they could use the SHIP funds towards that. And that helps reduce their premium dollars. So you can see how valuable that SHIP funds can be if the hospitals get an idea that they can have that flexibility with their program. There's always something if they're involved with accountable care organizations, gosh, the care coordination training, the navigator program, and I see there's a big push with the antibiotic stewardship program. We've been focused so intently on inpatient. Now it's expanding into the clinics and into the physician practice and outpatient setting. A lot of times you pick maybe the top 3 or top 5 operational needs and make a list of that when you're doing your assessment. If you've got a list of 50 things, sometimes start narrowing back down, and that really helps to get yourself focused when you do the assessment. Like I said, as you're doing the assessment and getting your application together and explaining to the hospitals, like I said, you know, there's all sorts of things going on with new trends and regulations. I noticed that I looked at the latest rules that came out from CMS, increased push towards telemedicine, and they're expanding into these applications, being able to communication through your smartphones. There's new billing codes that are coming out for there. Is there somebody that can do a lot of training on there to help people? Can you do some training with the hospitals? Maybe a group of them want to bring somebody in to help learn all about the new telemedicine codes, or how they would select a vendor to bring in telepsych. All those things can be useful and can be used if they're going to do an individual group project. Chronic care management, we know that that's a big factor these days. A number of hospitals are moving, especially upon accountable care organizations. As you move towards 2020 with value-based purchasing, hospitals will be accountable for how they're going to have to coordinate care. And if they haven't started down that path yet, there's a way that you could bring a consultant in to explain how to do chronic care management. If they haven't done that, there's plenty of opportunities to do that. Customer service, big push not only in the clinical level, but also in the patient access area, the registration. Instead of being business office registration, it's now called patient access or revenue cycle program. Anyway, that cultural change, and a lot of people don't know how to, to look smart, be smart, professionally dressed. All those things are part of culture, quality improvement, hospital operation. Trends going on with provider-based clinic, and of course we know with the opiate and prescription use. Maybe not necessarily, we've got to be careful about crossing grant programs, but there's different software programs with medication management, medication reconciliation, about tracking prescription use. If you can use that, those are all wonderful programs that hospitals can use and apply the SHIP program for that. Okay, so let's look at the individual hospital application. You're helping the hospital fill out their particular application if you're the program coordinator. And I really do encourage all the hospitals. Sometimes it's that personal call or an email from you if you're the SHIP coordinator to the hospital CEO or grant coordinator, whoever it is. And they maybe just don't understand, like I said, if they're new or they didn't participate last year and they think this is a good deal now, they've got a new need, about how to do that. You always have to go through the investments. Have they done their reporting for their patient satisfaction and so forth, and not then full speed ahead with all the other new ideas and guidelines that they can use the program for. And remember, the hospitals, and I stress to them, this is an opportunity for you. This is a rural program. So often hospitals complain that we never have any grant program, never have any opportunities. And here's a grant program, be what, about $10,000 next year. There's been some additional funds added to it with the new act that came out that was passed that increased funding both for Flex and SHIP. That, the policymakers are paying attention to rural. They're making sure that there's funds available for our rural hospitals. So I strongly encourage them to take advantage of that. Although if you don't use these funds, then Congress is going to think rural hospitals don't need any funds. And just, sometimes they just don't understand that there's a lot of flexibility. And if they don't individually want to work with, we'll partner with a neighborhood hospitals we've talked about in the consortium. And bottom line, there's sometimes you have a hospital that simply just declines. And, it frustrates me because I think there's so many advantages that they can use it for. But if they don't in the end, and a couple times I've had it where hospitals said, we've got a CEO changeover and we've got the chief nurse resigned and and that, they said, we're just not going to do it this year. And so bottom line, you just give them a pass, but you always keep coming back every year and asking them. Just because they didn't do it last year doesn't mean that they're not going to be ready. They might have a new person in place that understands it, willing to take advantage. Okay, so the hospital wants to pull their funds, the consortium activities. What's my responsibility as the SHIP coordinator? Do I have to do it? Do I have to be the one that coordinates? No, not necessarily. If you're staffed to be able to do that, some state offices are able to do it. I know some state offices are, like Michigan and Colorado, they work through a non-for-profit, and they've got staff that can do it. Some of the offices that are maybe have smaller staff, it might be harder for you to do it. You don't necessarily have to be the one that does it. Like I said, there's a lot of flexibility at the SHIP program, but you do have to set in motion for the processes to take place. And if you are going to be the one, you're going to have to be able to organize the activities. You've done your needs assessment. You've looked at the trends. You've identified the hospital's needs. And you have to be able to designate the funds for the program. And how are you going to track expenses? If you're going to be the one that does it, you're going to have to be able to write the contracts to the consultant, or you're going to have to set up the educational. Maybe you're doing a coding boot camp. You're going to have to hire somebody and set the program up at one of the hotels or a meeting room or whatever it might be. Or some people use an outside consultant, or maybe you make it. Many of you I know use the State Hospital Association, and they're great for it. Some of you have to put an RFP out for it, and that's the challenge sometimes. It takes time to do all those things. So I always advise do this prep work ahead of time. And so you have to do an RFP, and your subcontractors, you probably have a list of those that you find that you're able to work with it. But remember that you can do more than one or two activities. If you are going to pull the funds, sometimes you only need 2,000 or 3,000. Sometimes you need 8. Sometimes you need 30,000. So it just depends on your activities. You don't have to be limited. But you as the SHIP coordinator, you have to make sure if they're going to pull their funds, that whole process is set up with the consultant or with the association, or maybe one hospital takes the lead and several agree to pull their funds with that. You just have to make sure that in your grant application for the state that you're going to take responsibility and make sure that that gets done. So you say, well, some people don't really understand the value of the group projects. That's one of the reasons we wanted to talk today is why do you want to do that? Why do hospitals want to do it? Originally, that back in 2002, the idea was taking advantage of the pool funds. But I also think there's a great value in sharing, because when several hospitals come together, you get best practices and learning. You learn from each other. I do a number of peer group meetings, and I know a number of states do that, peer group meetings. And, the hospitals, they love having the educational programs, but you know what they like best? Is that they like the round table afterwards, that they can hear what somebody else has got an issue or a new idea, whatever. But, when you do these group projects, it really promotes best practices and learning. Increases the value of the dollar, better bang for the dollar, that old expression. Encourages the hospitals to share and partner, and that's one of the original intents of the SHIP program. And you can otherwise, some of these programs aren't attainable. Some people like to do the Studer program, and Studer can be expensive to implement, or Brian Lee's program. But if you partner with two hospitals together, often you can share those resources. But ideally, if you've got a hospital, 30, 25, 30 miles away, it's not too bad to partner on that. And they need a leader, somebody to take responsibility for that. And we've covered that a couple of times, but when you do that, just, there really is a great value in sharing the resources there. So how does it work? You could create your own activities. We had several hospitals last year in Illinois that chose to pull their funds together for a swing bed consultant. Carrie Dunning, we use Carrie out of Miami, Florida area. Anyway, she's just one of the, it doesn't have to be Carrie, it could be Stroudwater, different groups like that. But our hospitals, they wanted to pull some funds. There are about 6 of them that they really wanted to have an audit of how their policies and procedures for their swing beds were. They wanted to have some education on billing. They wanted somebody to review their charts. And so we brought Carrie in, and she did that. And also then we had some funds left over, and she did a webinar for the whole group of hospitals. There's just different ways you can do it. Real popular also is the coding boot camp. Hack Pro does a lot of, John Beard Group and others, they do a lot of those boot camps. And they're very expensive if a hospital's going to do that. And if they do the boot camp, how we do it in Illinois is that several hospitals pool their funds, and all their people go free, and then those that are from the outside, they help pay for some of the food and registration by a small registration fee. Different ways you can do bundling project. If you're a non-CH, maybe you're working on a total bundling project with a larger facility, a total joint. Maybe you want to do something where you're bundling all the way through swing bed or a home health program. There's just a number of ways that you can do that. You can participate in accountable care organizations, patient-centered medical homes. There are a number of training program certifications for that hospitals come together. And I know some states have even pulled their funds and did an MVQuip website where they could, build a database so that they can do some in-state comparisons. Just a lot of ways that you can do it. Here's some examples, and I've talked about several of them. Often our hospitals, they like hospital board education. I know one year in one of the neighbor states that they had several hospital board education videos done, and they really enjoyed those programs very much because they're little videos, 10-minute videos that you can find an expert, or maybe you can have CEOs. But somebody takes the lead on it. You can hire a consultant, or if you as the state office want to do that, bring somebody in. You can YouTube videos on maybe on conflict of interest for hospital board education, or hiring a CEO. A lot of those things are really valuable. Like I said, SHIP programs can do that. I know some of the Flex grant dollars can use that. If you are using Flex dollars, if you're the state Flex and SHIP, you just have to be careful. Those programs are separate, but you can certainly use those funds for that. HEDIS is health education. I never remember what the HEDIS is, but anyway, that's the quality measures for commercial insurance, and Medicaid also uses that. There's a great deal of lack of understanding for HEDIS measure. A lot of the hospitals don't understand that. It'd be a great pool project for people to learn how to do that. There's a national organization that does all the HEDIS recording, and they're going to have to know all about that. Navigator program, pharmacy compounding. There's a new requirement coming in 2019, December 2019, for sterile compounding that hospitals are going to have to comply with that. So there's just a variety of things that you can use for that. And you as a SHIP coordinator, you need to be able to put that list together to be able to help the hospitals to understand that. And I noticed this next year coming up, because the Meaningful Use program is really, the funding is moving away for that, and hospitals are going to have to continue their journey for advanced care information, that you can use the fund for some training with meaningful use to support interoperability. What about learning more about merit incentive payment systems, software programs to help providers to track their measures, a variety of ways that you can do it. Maybe participating in health information exchange. Some hospitals may be able to use their funds towards that. So you have to think that there's always ongoing new programs and trends that you as a shift coordinator providing a wealth of information, and you're kind of the stimulus out there, a way to help the hospitals understand how they can best use those funds. So how do you find those qualified resources, hospital suggestions? Like I said, you can use the funds for more than one project. You have about $10,000 each. And we've gone through many of those things. And you can certainly do individual projects. You can break those dollars up individually to several different ways. But always have to look at resources. And I'm happy to share different listing of vendors that we've used or consultants that we use. I'm sure the National Rural Resource Center, they have a wonderful listing of groups that have patient satisfaction surveys that are approved by CMS. Just contact those resources if you're looking for a list of those vendors. I know I talked with somebody in Florida and Georgia, a couple of people there, and they have several CPA firms that come in and do financial assessments. And if you don't know those names, we're happy to share that information with you to get you started. Group projects, like I said, population health. I know our organization does a lot of training on chronic care management. I'm not promoting them, but there's certainly a lot of different groups out there. I know the Rural Health Clinic is starting to do quality reporting. I know the National Organization of State Offices is working with Stroudwater doing a pond project. You could certainly help the hospitals, and they can participate in those programs. Like I said, you can see all the different projects that we've done over the time. We've done admission, discharge, transfer, provider eligibility when the patients come through the emergency department that helps with the billing processes. All those are great opportunities for you to be able to help our hospitals learn about that. So we've talked a lot about programs. We talk about your responsibility as the shift coordinator, the role that you play, and in your job to really help the hospitals understand the program and how best to use it, to, give them ideas for the programs. If you're helping them figure out, you can do a needs assessment. You can have an advisory committee to get those ideas so that when you're putting your communications out, you have the wealth of information already together, and it'll help the hospitals to better understand. Like I said, often I contact the hospitals individually. You can do it by email or general posting on a website. Best way I like to do it is set up a webinar, just like we're doing today, and then follow up with the hospitals individually. If it's a hospital that's really decreased the number of beds that they've had, that they might have been an 80-bed hospital, now they're 49 beds or less, you need to call them or send them a listing or information about the program so they have the opportunity to apply for it. So one thing you have to be, once again, careful is crossing funds, because most often if you're the shift coordinator, you're probably the flex coordinator too, to make sure that you don't use the funds for the same thing. I know there's a number of what they call the HIMSS, that's the reducing admissions through the hospital associations, and there's a number of EMS programs. There's already funding for those, so they really aren't applicable for SHIP. And sometimes, hospitals say, well, gosh, I really need money for EMS. I want to buy computers for the ambulances. Well, that's not necessarily something that you can use the funds for if they've already got another grant project for that. So you want to be careful about that. But I strongly encourage that once you get the application and you know the SHIP program's coming on, you've got a list of the SHIP menu, as you've done your needs assessment, you've done all that pre-work, put together a webinar, and then, send the information out to the hospitals and be available. Call them, help them, whatever it might need, because you want them to take advantage. This is a program just for them. They're a rural community hospital. Like I said, you really then become the taskmaster. Often I'm said, I'm the taskmaster. I have to follow up. I have to make sure the hospital completes their application on time, gets it back to me, gets all the information into the scorecard that we have to do for placing all the hospitals in one particular category, whether it's value-based or bundling or whatever it might be. And you have to set your time frame. You have to do all the follow-up. And the big thing is that if you've got a well-explained program, you've done your preparation time, you know the different kinds of programs and needs assessment, and that you're there as an excellent resource for them, the hospitals, there's confidence in do that. They can do these consortium programs. And I asked Maddie ahead of time how many hospitals, how many different states have done consortium, and about over half of our states have done consortium projects. And so I encourage you to do that. Like I said, it's a great advantage to be able to pull those funds. Sometimes it's discouraging when the hospitals say, I don't want to participate, but don't give up, and give them the different options. So the SHIP challenges, let's talk. What do you do if the hospital's not able to spend their money? Sometimes I get to the, the hospital, oh yeah, we're going to use this project. This is their need. They really wanted to buy this software program to help with medication reconciliation. Well, they ordered it and the software didn't come in time. Well, you help. They have to go through and take another project within the SHIP menu or the options that you provided, and you have to make sure that you get it done in time. So you really have to talk with them and make sure that they know that they're going to get their funds spent in time. It happens, often happens. The biggest thing I encourage that if you're making changes, that you have to have a paper trail that has to meet within the investment requirements. Consultant, that sometimes happen, you hired this consultant, well, they're not available anymore, or they join a system. I strongly encourage you that the hospitals, that just because the hospital is part of a system, they really need to participate. And I've started working with our systems and say, well, what would you like your 3 or 4 hospitals to do? Is there a special project that you want them to use the funds for? There's no reason why you can't give that SHIP grant to the system if they're going to use that to work with their 4 hospitals or whatever to do that. You want to make sure that it's available for them to use. What if the state presents a consortium and only 2 participate and you need 6 for the project? Well, you go to Plan B. And it's constant being on your toes, with the project, that you have to, communicate with the hospitals periodically. Once the application's been approved, you've got your funding, you communicate with the hospital. If you have to write a grant agreement or a contract, whatever your process your state uses, ongoing communication with them. Are they getting their projects done? Are they working with their consultant? Because these things do happen. I remember the old, let's talk kind of thing. What's going on? What questions do you have? What's frustrating is you finish their SHIP project. It's May or June, and the hospital hasn't spent their money. What do you do to help them to get that done? Because you want them to take advantage of this great opportunity, a grant that provides them wonderful flexibility that helps fill those gaps in those hospitals. So if you want to take a few minutes,
You can press star 2 to unmute your line if you do want to ask a question. Otherwise, you can type them in the chat box.
Okay. There's always something that goes wrong. I don't think I've ever had a year doing SHIP when there isn't one thing that goes wrong. There's always a hospital that forgot all about it. They changed SHIP coordinators within the hospital, and the project didn't work out. So happy to answer any questions. Anybody have any issues that they've had to deal with? Surely that's, this is your first time. Sometimes you wonder, how do you get started? Have you sent any information out to your hospital? Any questions? If you don't have any questions or a chat, feel free to share my email. I'm happy to answer any questions that you might have. I often know that when you have a large group, sometimes we don't have questions. When you finish, you might have a question thereafter. I know when we're going to be having the competitive grant coming up. How do you move forward with that? If you have a question, I'm happy to answer anytime. I really think it's fun. I really enjoy the SHIP grant project because there's so much flexibility to it. And I think if you push that flexibility to the hospitals, that they can use those funds for a variety of things, that it's really an asset for them. And I really think that it's important if we can continue to do a great job with the SHIP, because that tells policymakers that rural hospitals still have great needs out there, and we need to continue to keep the program alive and open. And I think it's great that they've added some additional funds for that.
Pat, this is Sally from the center, and I say, frequently states will see that they get towards maybe the third quarter that, like you said, the hospitals have something's changed, either the coordinator or system, or fewer participated in the consortium activities. So the state is faced with having carryover funds, like maybe $40,000, because 4 hospitals didn't use all their funds or had things change. What kind of